a formality. This is a seminar series that really is very much aligned with what we're doing, directions we're going, and it's really become a forum for exploring how it could be more effective in terms of health and healthcare, and an investigation that could go ahead and to make a difference in an area like that. It goes without saying that telehealth has been instrumental with health and healthcare, delivery of health and healthcare, and trying to optimize health and healthcare during the pandemic. So what we did was ask Charlie MacLean to put a session together that really covers the challenges and opportunities that have really covered the rural northern New England area. Why Charlie? Well, Charlie has really been the architect of health and healthcare at the primary care level in Vermont and regionally. He's provided leadership for primary care, for the College of Medicine, for our healthcare system, but equally important, he has developed research programs that have assessed effectiveness of health and healthcare at the primary care settings, and that truly has made a difference. It made a difference prior to COVID, and during COVID has given us tools that have allowed us to be able to fulfill responsibilities that otherwise would have been difficult at best. Also, as a partner in the Northern New England Clinical and Translational Research Network, Charlie has worked with his colleagues in Maine and Vermont and in New Hampshire through the Practice-Based Research Network to develop initiatives that have been really key and becoming increasingly important. So I'm going to turn it over to Charlie. He's going to introduce the panel that he's put together, and I'm really looking forward to today's presentation and discussion.
Great, thanks so much, Gary. Give me a thumbs up if you can see the title slide. Great. Welcome everybody. I'll start off by saying we put together a panel of folks who are listed here. And this is going to be a real rapid fire potpourri presentation of some of the work that people have been doing over the last, the era of the COVID pandemic, really. And I'll introduce each speaker as we go. Nobody has any conflicts to disclose. And here's our kind of outline. We're going to try to stick to 10 minutes, rapid fire with me at the beginning. At the end of this session, I hope that the audience will be able to describe impact of COVID on the use of telehealth in the US, understand some of these novel uses of telehealth in a variety of settings, and then the importance of training in how to deliver high quality telemedicine. So what is telehealth? So telemedicine is what I do in primary care, which is really telephone and video visits that's evolved rapidly during COVID. Other things to think about are telemonitoring. Increasingly we're having folks in our offices who have implantable cardiology devices, pacemakers, and other monitors. CPAP machines now talk to the home base and give you a report card on how well you're using it. Home health has technology to measure people's vital signs, and a lot others. The other things I think about are sort of non-contemporaneous communication as a form of telehealth and telemedicine, where we're increasingly using the patient portal for people to ask questions, get them answered, or more formal e-visits where people report their symptoms and we respond in a formal way that's actually billable. And then, we've really had to pivot a lot on the educational side in our office, where we deliver academic detailing and echo programs, which have always been designed to be video mentoring. And then we're not going to talk about this too much today, but all of the app-based programs now that are being called either e-health or M-health, mobile health kinds of applications. So that's the sort of big picture. This is a slide that shows the growth in telemedicine. And if you focus on the top, this is ambulatory visits in one large academic health center over the course of the COVID pandemic. So here you can see the proportion of in-person in the darkest color, and then home visits in the lighter color. So pretty steady. Hit the pandemic, April, May, June, you can see the replacement with virtual visits for a certain proportion, big drop in volume, recovery in volume, And then out a year later, you can see there's still some persistence of virtual visits. And I think that's been our experience here at our institution. If you contrast that with behavioral health, you can see it's been a total pivot that never came back, right? So that I think we've also seen locally. This is a study that from Michigan, where they used Medicare claims to look nationally at E&M services for Medicare beneficiaries over the pandemic. And so you can see here, all visits in orange, in-person visits in this kind of aqua color. They're overlapped here, in-person visits plummet, you get the recovery, and then again, you have this gap that's filled in by telehealth. So there's some studies that have looked at that. So huge growth, some changes long-term. If you look at the growth and what's been published in this arena, it's been astronomical. I pulled this a week ago. So the 2022 is only part of the year, but the number of publications in the area is just crazy. So I'm not sure we can say a lot about best practices yet, because it really hasn't evolved and people haven't had an opportunity to study it well enough, even though people are all publishing, here's what we did at our institution, or here's a specific instance of telehealth. One slide on sort of advantages and disadvantages. During COVID, obviously the contagion issue, travel convenience. One thing I never thought of before was this sort of participation by distant family. I now do visits where I have an elderly person whose son or daughter is in California, and we actually bring them into the visit on an iPad or on the telephone even. A lot of technical issues, bandwidth, this ethical issue of like who's in the room. Is there somebody else lurking? I do video visits where the spouse is walking back and forth, or someone else wanders through, and there's issues there. Health equity issues around access and privacy, and those two interrelate. Obviously, there's limitations on what you can do. And we really don't know this sort of effect on sort of personal connection. Most of my visits are with people I've known before, which makes it kind of easier. And then there's some policy issues around reimbursement. To illustrate that, here's sort of like COVID coverage flexibility. How do you do it? Traditional Medicare. What about Vermont Medicaid? What about New York Medicaid? What about licensure requirement? I'm now licensed in Florida so that I can do telehealth there. This paper is really interesting recently from JAMA around this issue of if it doesn't get paid for, it's not going to get really implemented. So resolving those payment issues being kind of essential. And then we did a little study locally here with some med students, and this is my last slide, where we asked primary care folks in particular, like what's the right ratio of in-person to video visit? And when we asked about a condition like diabetes, it was like, well, we got to check their feed, and there's certain things in the physical exam that are important, but a lot of it is just talking about the data that are on your meter, or continuous glucose monitor and how you're feeling, and you can measure blood pressure at home. And the primary care docs who we asked this question of what's the right ratio, they really love the sort of one-on-one concept, like, or every other one-to-one. So I'll see you once, next time will be video, back and forth. When you look at it, something like anxiety, depression, they were all over the map. Like it was really, like some people, wanted whatever ratio. So I think this is really evolving. And I show this slide just to get people thinking about what makes sense. We have some specialists now who just do video. They just have converted entirely to video consultation. So with that, I'm going to stop, and I'm going to introduce Alexa, who's our next speaker. And she's a neonatal and pediatric neurologist at Maine Medical Center and Maine Medical Partners, and a clinical researcher, and she's the director of the Barbara Bush Children's Hospital Scholarship Academy. She's an alum of Larner College of Medicine, and she's assistant professor at Tufts and has a master's degree in CTS, and she's the lead scientist on the NIH-funded AcuteCare Research and Role Disparities Project. And she's going to talk about telemedicine to improve identification of hypoxic ischemic encephalopathy in neonates. So Alexa, I will run your slides. Just tell me when to advance.
That's perfect. Thank you. And this is going to be a whirlwind tour because I promised I would keep it at less than 10 minutes. So this is just thank you for all the support, especially from the clinical and translational, from the NNE-CTR, because that's what got this off the ground. So next slide. A lot of people don't know anything about what goes on in the NICU, so I just thought I would ground us in a case really quickly so you kind of understand the flow of what I do. So this is a little baby named Aaron who was born at term after an uncomplicated pregnancy. And when the water broke, as his mother was about getting ready to deliver him, the umbilical cord came out. And so what that meant was with every subsequent contraction of the uterus, he was being deprived of oxygen and blood flow because it couldn't get through that kinked umbilical cord. So when that umbilical cord prolapse was identified, mom was rushed down the hallway for an urgent cesarean section under general anesthesia. He was born in a small community hospital in Maine with less than 500 births per year. And because for whatever reason of good luck, the pediatrician happened to be in the hospital around 7 o'clock in the morning when he was delivered. And so she was there to give him chest compressions. You can see the bruising on his chest from the several minutes of chest compressions he got while they successfully intubated him after 4 attempts. And he had pretty significant acidosis with a cord pH of 6.8. And again, because all the stars aligned for this little guy, he started on the treatment for this kind of a traumatic birth, which is called therapeutic hypothermia. He was started on that treatment by the time he was 3 hours old when the transport team went out from Maine Medical Center to go pick him up at this community hospital. And so the blanket that he's laying on is the cooling blanket. And what that does is it brings his body temperature down to about 91 Fahrenheit, 33.5 centigrade. And we treat the baby for 72 hours, keeping them at that temperature, recording brainwave activity on their EEG, and hoping against hope that the cooling stops brain injury. Then go to the next slide, if you would. So the good news for this little guy, Aaron, is that the cooling did work. The MRI of the brain, which I'm showing you here, is a beautiful term MRI with no evidence of hypoxic ischemic injury. And he was discharged home on day of life 11, taking all feeds by mouth. And we can go to the next slide. Here he is at 2 years old, like completely perfect, no sign that anything traumatic happened. And so I've spent, like, my life's passion is to try to make this hypothermia treatment available to all kids who need it and who meet criteria, not just those who are lucky enough to be born at 7 o'clock in the morning when a pediatrician who knows about the therapy is there to call us. We can go ahead to the next slide. So you guys in Vermont will completely resonate with you about how rural both of our states are, the most rural states in the country. We have 2 tertiary care centers, whereas I think you guys just have the one in Burlington, but our 2 are represented by the red stars here on the map. Portland in the southern part of the state, Maine Medical Center, and then northern light eastern Maine Medical Center in the middle. And what seems to invariably happen is that these babies most of the time are born in the middle of the night when the roads are icy and horrible, and we've got to go out on transport to get them in these sorts of conditions. So everything takes a long time. And the thing I forgot to tell you is that we have to start this amazing hypothermia treatment within the first 6 hours of life. Because if we're late and it's after 6 hours, it doesn't do the same beneficial, it doesn't have the same beneficial effects. So this is a graph of all the babies ever cooled at Maine Medical Center. And I'm going to reveal the rest of the graph as we're talking. So I came to Maine Med after finishing my second fellowship in neonatal neurology. I came in August of 2012. And in 2013 and 2014, I went to all these community hospitals to teach them about the wonders of therapeutic hypothermia and how we could save these kids. And also to try to figure out when we were missing babies who would come to us, like, they were having seizures 24 hours of life, 48 hours of life, and sort of retrospectively, it looked like they might have met eligibility criteria. I was really, really working hard to raise awareness so that none of these babies would be missed. Next slide. So with the funding that I got from the CTR, the pilot study initially, we kind of did 2 things. And this was the first aim, where we built this hypothermia database on every baby ever cooled, both in our hospital and in Bangor. And of course, I don't have time to go through all the nuances of this, but we compared the size of the hospital where the baby was born to the outcome of either death or catastrophic injury on MRI of the brain. And the last line is the most important, which basically says if you're born in a small volume hospital where the births are less, do one more click for me. Yes, the bottom red ellipse here. In the adjusted analysis, if you're born in a hospital with a birth rate of less than 500, you're 7.5 times more likely to have this catastrophic outcome than you are if you were born in a tertiary care center. So we knew we had a big problem with these resources at these community hospitals. Next slide. So, this is sort of some of the educational outreach that we were doing, going out to the community hospitals and helping them recognize high risk versus moderate risk versus low risk babies. And I put these two Time is Brain posters here because one refers to Maine Medical Center and the other refers to Northern Light. And just to focus on the importance of the politics and making sure that the right names are on the right posters at the right institutions so everybody is happy and works together. This is an art form that they don't teach you in your master's in clinical research. Next page. So, what we were expecting pediatricians to do in the community was to be able to differentiate the baby in the top left corner who's normal from the baby in the upper right corner who's mildly encephalopathic. And they look a little different, but not that different, right? The mild baby's a little bit more splayed out than the normal baby. We cool the moderate and the severes, the bottom row, the kids whose brains have clearly been affected by hypoxia and ischemia. And what was happening was that we were missing the mild and the moderate distinctions were not being made very well. Next slide. And so what we, this graph is kind of showing now the results of this educational intervention, right? Going around and saying bad things happen when we don't cool babies, teaching people lots of stuff. And so you see that the numbers of babies that we cooled shot up from 2014 to 2015 up to 43 and 39. And suddenly I was feeling like we were cooling way too many babies. And what became abundantly clear was that there would be a role here for telemedicine to try to sort out which babies really met criteria. So the next slide. So this was the first telemedicine project that we did in 2017. For 1 year, we had the camera that I'm showing you here on this slide in the NICU just at Maine Medical Center. So we used, this actually was loaned to me from our telestroke program, and we captured data on every teleconsult that was done in the NICU at Maine Med for a year. Next slide. And sorry, this is kind of small, but basically what we did was we compared babies born within Maine Medical Center to babies born in community hospitals who had to be transferred here for evaluation for hypothermia. And not unexpectedly, we found a huge difference. So the babies born at Maine Med had their first neurologic evaluation when they were 2.1 hours old versus the babies who had to be transported in at 4.7 hours. And what was really, what really stood out to us was we only treated a third of the community hospital transferred babies. So 2/3 of these babies were being transferred to Maine Med for an evaluation for treatment they ultimately didn't require. And in previous work, I've done a lot of qualitative analysis of the parent experience, and separating parents from their babies when they're only hours old is incredibly traumatizing. So this is a very bad thing to do. Next slide. So, so this is the result of our sort of, as we're tracking what's happening year on year, the pilot, the one camera at Maine Medical Center decreased the number of babies that I cooled, by a little bit. The obvious answer was to put the next set of cameras in the community hospital and evaluate babies there. So next slide. So this is what we did in the second aim of the NNE-CTR funding. We bought 5 cameras and we put them in the hospitals, all with 500 to 1,000 births, trying to get the most babies we could. Next slide. And here's the data. So the babies in the tertiary care center, as the institution is getting better and better at recognizing them, they now get their first consult at 66 minutes. I think if you click one more time, we'll have a red circle maybe. Oh, no, maybe not. Go back. Sorry. So 66 minutes instead of 2.1 hours. And the community hospital, this was just stellar. We went down from 4.7 hours for their first consult to 98. And what was really, really cool is that we still transferred some babies for other issues like respiratory distress, but we left a whole 26% of them in the community hospital. And that's just improving over time. The more people get comfortable with the use of telemedicine, the more we're comfortable leaving babies in the community hospital. Next slide. So here you can see this really sort of precipitous decline because this project started in 2018, in April of 2018. And I've kept it going, even though I just had the 1 year funding for the CTR and then spun it into the first aim of my COBRI pilot or COBRI project. And so now I kind of have a new problem because now I kind of, if you click one more forward, I have a funny cartoon. I'm back to square one, right? I'm cooling 16 babies a year again. And now I don't know, like, I still don't know if these are exactly the right babies, right? So I'm gonna show you one more slide, I think, next one. So this is the AcuteCare COBRI project that I'm doing. This is aim 2 of this project. And this is only happening in tertiary care centers. So it's happening at Maine Med. We've recruited 5 so far. Northern Light in Bangor just went live, and UVM, I'm coming there June 9th and 10th, and we'll be hopefully live by then. And what happens is we have a baby who's at risk for needing to be treated with hypothermia. We do the telemedicine evaluation and we decide clinically whether or not they meet criteria. And if they're cooled, that's fine. And they meet criteria, they are not followed in the study anymore. And if they are not meeting criteria, then we do an MRI of the brain and an EEG to make sure that we're making the correct clinical decisions. And so we're trying to recruit 100 babies over the next year and a half, and God willing, I'll be able to do this. I don't know, it's a lofty recruitment goal, but we'll see. So next slide. Or maybe that's it. Oh, there we go. So yeah, so that's what I've been up to, and hopefully, I don't know how I did on time because my phone turned off. Oh, 11, sorry.
Charlie, you're muted.
You're muted, yeah.
Sorry about that. So I was just saying, we're going to hold all the questions until the end. And thanks so much, Alexa, for that rapid fire, excellent presentation. So Matthew Siket's an associate professor of emergency medicine and neurologic sciences at Larner College of Medicine. And he's the associate program director for our new emergency medicine residency program. He completed a stroke research fellowship at MGH and served for several years as co-director of multiple stroke centers in Rhode Island and in Vermont. And he currently serves as the co-director and PI of the AUGMENT Telehealth or Tele-ED EMS project that he's going to be telling us about today. So Matt, please begin.
Great. Thanks, Charlie. Can everybody hear me okay?
Yes.
All right, perfect. And Dr. Craig, that was fantastic. I'm going to change gears a little bit and talk about using telemedicine in the emergency department. And it's more for supporting one another, peer-based support. Absolutely, we want to establish the foundation to be able to have access to specialists like Dr. Craig. And as an ER doc who saw a lethargic 2-day-old in the ED just earlier this week, I want to be able to protect Dr. Craig so that I can call her when we need her and not predispose her when she's not needed. And so our project was born out of the noticing that at the UVM Health Network, there's been increased integration amongst our 7 hospital sites. And with that, some lowering of the bar to access our specialists from around the network without necessarily a proportionate increase in the number of specialists at our disposal. And so they're getting increasingly tasked to respond to calls. And we thought maybe this was an opportunity to help support one another in emergency medicine. So our project, we applied for HRSA funding in the start of 2020 and were successfully funded that August. And it's called AUGMENT, and that stands, it's a long acronym, Advancing Unified Guidance for Medical Emergencies with Network Telehealth for the Emergency Departments and EMS Agencies of Greater Vermont. And Charlie, if you can advance the slide. And so this is a 4-year project through HRSA's TNGP program. And essentially it's to, like I said, establish the foundation for peer-based decision support amongst our rural EDs. And we really envisioned this to be the hub based at the UVM Medical Center and interacting with each of our network affiliates We are one group of emergency providers that staff usually multiple hospitals. And so this would be firing up your telemedicine cart and speaking to a peer, a colleague that sometimes you're on shift with at UVMMC, but not so much when you're the sole provider at at one of our rural sites. And so our project has two arms. One is ED to ED peer-based decision support, and the other is Tele-EMS. So being able to provide sort of advanced individualized pre-hospital support for patients that are en route. And we had some advantages in terms of the timing. As Charlie pointed out, we have a new EM residency program, right? And so we would have our first class of senior residents that have a long leash, so to speak, and we're able to carry more of the volume of patients in the ED. And we had the opportunity to repurpose our attending physicians without necessarily downstaffing. And one thought was being able to field these calls from our network affiliates. And the other was, well, we learned from the great work that MaineHealth is doing, and certainly to our neighbors to the immediate east, Dartmouth's connected care model was one that we could certainly use as an example. And they were much larger scale at this point, and we sought to do something smaller in scale, but similar in design. And personally, when I moved up here in 2018, I had been involved in stroke operations, and we launched Telestroke in 2019. And I was asked to field telestroke, but I'm not a neurologist, right? And I wasn't going to pretend to be, but it was through that experience that I realized you don't always need the neurologist as much as you need an extra set of eyes and ears to help you parallel process in a time-sensitive emergency. So there's certainly a time and a place for the specialist, but sometimes we can support one another. And I wanted to seize the opportunity to do that. So as I mentioned, this is really to offload a proportion of consultant calls to potentially, when they're maybe not necessarily needed and we can support one another through peer-based support, potentially to reduce the number of ED to ED transfers. And this has become even more important on the back end of the pandemic, where, as we all know, the capacity challenges that we're facing throughout our health systems is really unparalleled. And so helping to maintain patients in their communities of choice and to avoid that siphoning of patients up to the mothership when there's not necessarily space available, this allowed us to help in doing that. And then also in the process, we were able to lay the foundation for access to our specialists, or also raising awareness to be able to flex virtual capacity to demand in potential disaster scenarios. So we kept it open-ended in terms of who was appropriate for peer-based support through Tele-EM, but essentially we encouraged it be used in times of volume surge. If you're single coverage and are getting overwhelmed, when there's someone with a lot of medical complexity and you really just want a second set of eyes and ears to help you work through the case. If it's a real time sensitive emergency, and again, we wouldn't insert ourselves into a trauma or a STEMI or a stroke if the wheels were already greased and there were good pathways in place. But if there was an opportunity to parallel process, then we wanted to help support our colleagues when we could. And then certainly as a bridge to the subspecialists. And pediatric emergency medicine has been a great example of that. And I'll share with you a couple of our first cases. And lastly, when we know we're receiving a patient, but want that opportunity for a warm handoff. So let's get to the bedside with the cart and let's get a sense of what you're sending and what we're to receive, so we can ensure the patient is stable from sort of time 1 to time 2, and there hasn't been a subtle change in transit. So implementation kind of kicked off in the fall of 2020. And as Charlie pointed out, the licensing and credentialing process was pretty robust. Most of our ED providers were already licensed in New York and Vermont, but those that weren't, that would potentially field the Tele-EM calls, became licensed and then credentialed at each of our network affiliates. There were a number of educational initiatives, both at the participating sites and within our hub. And we launched with our first 2 sites in July of 2021 and have sequentially over the series of months launched at all of our 6 network affiliates and are now live around our network. And it really is just a single call to our regional transfer center where we've introduced a 3rd lane. Previously, it was this is an ED transfer or this is a specialist consultation. And now they're prompted, is this appropriate for tele-emergency medicine? What we've noticed is that, sometimes our providers don't necessarily want to talk to the UVMMC emergency physician. They still absolutely want the specialist. Sometimes they want colleagues from other sites. And so we've since redesigned this somewhat. We've got a lot of lessons learned in our first few months, but it's been a work in progress, and I'm happy to report that we're up and running. So let's talk about our first 6 cases. So case number 1, there was not much to do, but it was a mental health hold at one of our rural affiliates who became COVID positive while boarding in the ED, and the provider there just wanted to talk logistics. What does this mean in terms of the bed search, and are there any new interventions that need to occur? This was early on in the pandemic. They were able to remain at the affiliate. Our next case was an elderly patient who had a fall and a traumatic subarachnoid and a complex cartilaginous ear laceration. We had a traumatic brain injury pathway recently developed, and we were able to reinforce that use of that pathway through Tele-EM and able to sort of casually curbside our specialists to come up with a closure approach. And the patient was able to remain at the affiliate without needing transfer for specialty care. Our third case was a subacute infected burn. Really didn't need the hands of a burn surgeon, but needed a closed loop follow-up arranged, which we were able to orchestrate through Tele-EM. And then case 4 was interesting. This was a toddler with respiratory distress, secondary to RSV. This would have absolutely have been a transfer, but being able to get our pediatric emergency physician on video, we agreed to observe the patient for a few more hours, at which point the child turned around and transfer was averted. Case 5 was a critically ill patient that absolutely needed transfer to the ICU. And this was sort of overwhelming to our critical access site. And our intensivist was able to get on the line and help to manage that period of time between sites. And our last and most recent case was sort of a real complex multifactorial respiratory distress from asthma and COVID and some anxiety that was really peri-intubation upon arrival to a critical access site with only a PA on staff. Intubation was ultimately avoided. ICU admission, which would have been the last ICU bed at UVMMC, was also avoided through Tele-EM, and the patient was able to be transferred to the ED and ultimately admitted to the floor at UVMMC. So I would say that there is some success here, but we're still very early on in the process, and we're building and refining as we go. Let's see. So I'll just share a couple of lessons learned, and then in the interest of time, I think I've gone over my 10 minutes. So we need to make this easier to activate and use. Some of our participating sites were concerned about medical legal concerns. What if I choose to use this and there's a bad outcome? What if I choose not to use this? Would I be held to a different standard now that this option exists? And like I said, some of our partners want to talk to one another and not necessarily the hub. So we've sort of rewired the network, so to speak, so that the affiliates can partner with one another and avoid the hub altogether if needed. And right now we treat our hub space as another treatment room in the ED. And sometimes, our shifts get pretty crazy and the user experience will suffer if we're feeling pulled away with competing priorities. And so having a separate staffing model where there is a dedicated telehealth provider would certainly help that. And we're just working out how to accomplish that. And lastly, and rightfully so, most of our callers still want Dr. Craig. They don't want the ED doc, right? And that is entirely appropriate. And we need to know when to just get out of the way and grease the wheels for the specialist. All right, and the next slide. Lastly, I'll share very quickly. Tele-EMS has been a little bit more slow to roll out, but this has been useful in non-transport decisions. certainly in our rural network, there are long transport times, and there are some patients who may not want to come to the ED, or some that may not need to come to the ED. And COVID has been a common use for this. So getting on camera and talking about alternatives, redirecting to primary care, or certainly okaying high-risk refusals has been a useful use of our second arm of this project so far. And we'll just go ahead and skip ahead. Yeah, and I'll just lastly say, in terms of the pandemic in particular, we've dabbled in tele-education. We siphoned one of the medical students from Dartmouth to our intern class through a virtual visiting student rotation in 2020, where we virtually immersed them when they weren't physically allowed into the ED by wheeling them around on an iPad and having them virtually rotate in our ED. And that proved to be successful. And we've talked about broadening that model to some of our global health partners so we can have bi-directional educational experiences. We certainly look forward to growing into the remote monitoring space and virtual rounding on observation patients. But so far, this is really just getting started, and we're learning as we go. But thank you for your time.
Thank you, Matt. Appreciate it. It's really exciting that you've got this growing emergency medicine residency program. It's a real asset. All right, so our last speaker is Tracy Jalbuena. And Tracy is a board certified emergency medicine physician as well. And she's the clinical lead for quality at Penn Bay, Penobscot Bay Med Center in Rockport, Maine. And she's the clinical lead for telehealth for the MaineHealth system. She obtained her MD degree at the University of North Carolina at Chapel Hill, and did her emergency medicine residency at Ohio State. So Tracy, I'll pass it over to you.
Thank you. Thanks, everybody, for attending. I'm going to blast through this because I know we're a little short on time. So I'm going to talk about quality in telehealth and my two roles at MaineHealth, one on the telehealth team, the other on the as a quality officer at Penn Bay, really feed each other quite nicely. So I don't particularly like the word quality because I think it has different meanings in different places and people have different assumptions about it. But the way I approach it is the following. How do we know we're getting it right? How do we know we're doing a good job for patients? And conceptually, I like to break it into two groups, basically, case reviews and then big data. All right, so let's talk about the word quality a little bit. As I said, and as most of you know, has a very particular meaning in healthcare with a lot of assumptions and implications that's different from the lay use of the word. But there are a lot of situations in which the different meanings of that will get conflated with each other. So now we're going to talk about this case review with that in mind. So there has to be some system in place to look at cases. And this is to detect when processes are broken or when there was simply an error or a mistake. And I'll say that most of the time, in my experience, it's that there was a system error or a process that was broken or a communication gap rather than a particular individual clinician making a simple mistake. And as you know, at most healthcare systems, there is usually almost always some sort of event reporting mechanism. And that's usually some kind of software platform or app that all the employees have access to where they can file an event. And this could be at MaineHealth anyways, this can be anything from that railing was broken to the lab phlebotomist was rude to me to that physician made the wrong diagnosis. And then there's this complicated series of responsibility lines in which all those cases are funneled to the right group. So the broken railing would go to facilities, the rude lab worker would go to that person's supervisor, and then the physician and APP medical decision making goes to some sort of peer review process. And so what we discovered early in the pandemic when our ambulatory video visit volumes skyrocketed, like most people, is that we had no mechanism for tracking whether or not we were having cases and whether or not there was any pattern of broken processes or systems with telehealth tools. And so we went to the stewards at MaineHealth of our app, our software platform that is event tracking, and had them incorporate into it a flag basically for the submitter to be able to indicate whether or not the event that they were reporting was somehow related to telehealth. And then now the telehealth team is able to collect those on a regular basis, review them, and look at patterns. And what we might expect just at face value is that the emphasis on types of events might be a little bit different for telehealth than in other parts of healthcare delivery. For example, we might expect to see a lot more problems with privacy and security or technical equipment issues, perhaps maybe, than other places. On the other hand, we're not going to see any problems with medication administration for the most part, since most telehealth tools preclude administering medication. So here's an example of a summary of the types of cases that we've seen. This was collected several months ago, and sort of as expected, you can see a lot of privacy and security events. But we have had several other events that were illustrative of a broken process or a broken system issue, so that we were able to go and try to address that system issue. So for example, I'll tell you that we continue having many cases in which some sort of behavioral health intervention or even a medical intervention is necessary, but the patient is physically distant from where the provider is. And so we have to send out EMS or the police. And in several cases, we actually didn't know where the patient was located. They turned out they were not at their address, which is included in the electronic medical record. And this resulted in the police going on a wild goose chase across 2 different Maine towns, trying to actually find the patient, and address that was listed actually didn't exist. There was no building at that. And, you know, this is a horrible waste of resources. And not only that, it's risky for the patient. And it's very different from an in-person interaction where the patient's right in front of you. You can do what you need if they syncopize or go into arrest or say that they're suicidal or something like that. So we are building into our workflows technical issues. Yes, you know, part of it is reporting. So there's a comment about surprisingly few technical issues. And you know what tracking like this actually does is allow you to identify where you're doing it well, where you need to fix things, what sort of fix you need. Was this just a one-off and the solution's already in place, or, you know, do you actually need to address and change a workflow? So that has been really valuable and would continue to be valuable for us in order to highlight issues. And I think there's another ripple effect of this. One is that there are several ripple effects, actually. The first is that our telehealth team, who are for the most part primarily non-clinical, on a day in, day out basis, sort of on the ground basis, get an idea of how their tools are working and where the potential pitfalls are for the clinical teams, so that they get a much better, more rich, robust situational awareness. I love that word because I come from emergency medicine, so that when they're building tools in the future, they can say, oh yeah, I have this robust understanding of where this might be a pitfall. We're going to build this to avoid that pitfall in the first place. So this is a process over time in which everybody's skill set, particularly the operational people who are building telehealth tools, is improving and increasing over time. Okay, so let's go on to the next slide for the sake of time. So the next slide, now I'm going to shift and talk about big data. We're going to talk about big data. So this is big business in healthcare, as we all know. This is where to measure some sort of healthcare system's performance or practice performance or hospital level performance, big data from patients aggregated and then compared with some sort of benchmark. And obviously we have to do this. This is a very fraught process. There's a ton of conflict and debate about, are we doing it right? Where do we get the benchmarks? What are we measuring? Nevertheless, if we don't look at this, how are we going to know if we're doing a good job? Somehow we have to look at this. We have to grapple with this. And so what happens is, essentially, there are all these national organizations that go through this process of stewarding metrics. Their mission to define metrics according to the best evidence, and then help determine what the benchmarks ought to be. So for example, who is it that gets to decide that hypertension is defined as 140/90? Why not 150/100 or something else? So there's an organization that stewards that definition. And then the leadership of a healthcare system, clinical leadership, goes through some process of determining which clinical priorities they want to focus on in their system in order to measure over time to see how progress is being made to that goal. And usually typically there's some sort of regular report or dashboard that summarizes this information. So let's go to the next slide and I'll give you an example and how this intersects with telehealth. So we all know that the pandemic caused telehealth to explode. And I heard somebody recently describe that it went from being a boutique service to being part of the mainstream of medicine. And it's baked right into the way medicine is practiced. And as such, we are now at a point where we, telehealth, people are being asked to show its impact on patients' health in a way that we were not really asked for prior to the pandemic. We are now being asked to produce big data, and we have to figure that out. This is not something that telehealth has historically really been good at or has been focused on. And here, I'm not really talking about patient satisfaction or experience, although that's one component of it, but that's not really what I'm talking about. I'm also not talking about operational measures like volume, utilization, and geographic distribution. I'm talking about solid clinical outcomes. And these are not easy. These are not easy to measure. They're not easy to define. They're not easy to get. So it's not the low-hanging fruit, but it's important because we're going to be asked. In fact, we're already being asked to do it. So here's an example for MaineHealth. These are the metrics we can see that are on our MaineHealth system dashboard for 2022. Every month, everybody learns how they're doing. I made up the targets are real, but the performance there, I made up all those numbers. That's a pretend mock. And so here's what we should be striving for. We take, in my opinion, we take the clinical initiatives that our leadership has already decided are important for your system to look at, and we should be measuring how are patients who use any of a number of telehealth modalities doing, how are we doing on those metrics? The very same goals that everybody else across your system are being asked to strive for, not different goals. So it should be part and parcel of your clinical initiatives across your healthcare system. Because after all, we're all supposed to be driving towards the same things for the patients. Now, again, there's a ton of debate, there's a lot of conflict and argument over that. Nevertheless, telehealth needs to be part of that big debate rather than off in an isolated corner measuring things that aren't related to what everyone else is measuring. So when that happens, there are some very distinct logistical and operational advantages to piggybacking on the clinical outcomes that are already defined as priorities. Number one, you already have all that buy-in. Leadership has already decided these outcomes are the priorities. So you already have all that buy-in. And here's a really one that's near and dear to my heart because I spend a lot of time trying to get data out of Epic. Your system already knows how to measure this stuff. All the Epic definitions are written. The reports for how to capture this are already built. They are known quantities in your data analytics and your EMR. And anybody who's tried to capture some ideas out of electronic medical record will know that that will quickly get you off into the weeds and turns out to be more difficult than it sounds like it ought to be. So the fact that the foundation for measuring stuff out of your EMR is already built is a huge operational advantage and will get you much farther, much quicker. So let's go to the next slide. All right, so I want to back up and go back to the big picture here. Measuring our clinical outcomes in this way of telehealth utilization allows us to accomplish this fundamental task, I think, which is facing the telehealth field right now, which is to determine what are the appropriate indications for each of our telehealth tools. And Alexa and Matt, you both sort of referenced this in your individual talks. How do we know who this is good for? What clinical scenario should we use this tool for? Because of course, telehealth tools are just like any other tools in medicine. They're helpful in some circumstances and not helpful in others. And if you apply it in the wrong circumstance, you have the potential to actually do harm, waste resources, or actually do harm to that patient. And frankly, it would be sort of foolish and naive for us to think that all the telehealth tools are going to be equally useful everywhere all the time. And so we really need to start building up or continue building up this body of evidence that tells us what are the right indications for which telehealth tool. And the reason I put a spiral in this slide is the following, because I think that we can either end up in an upward spiral or downward spiral. The upward spiral is one of good outcomes because we know what the indications are. We're using the tools appropriately. And so now we're generating good outcomes that goes along with education of clinicians and the clinical teams, which increase trust on both the part of the clinical teams and the patient. They trust it because they know that it's being used wisely and we're getting good outcomes, therefore, which means we have good, appropriate utilization and we have increasingly robust clinical expertise across your system of those tools. On the other hand, you could also end up in a downward spiral of inappropriate application, therefore poor outcomes, loss of trust, declining utilization. And it's all driven by evidence, really. I mean, I think Evidence is my reference point in the world, and I think this is a huge task now going forward for the whole telehealth field, which is to, one, generate the scientific evidence that will lead us to have good metrics and measures, how we measure them, how they're defined, what our benchmarks ought to be, so that we can have good outcomes, so that we can use the tools appropriately. People trust them, they like them, they use them, and that's how we know we're doing it right. Thanks.
Thanks so much, Tracy. That really resonates with me in terms of we're such early days on this. We really don't know what's the right way. And we haven't, there's really a paucity of getting the patient perspective on this as well. Thanks also to Alexa and to Matt. So for the audience, please raise your hand and we'll recognize you, or put something in the chat and I'll monitor that. Questions or comments? So Gary.
Well, obviously telehealth has been transformative, and the examples that were presented, I mean, make that really clear to us. What is going to happen with reimbursement following the pandemic?
You know, I can say I don't know. You know, I think if there's a proof of this being an effective way to, you know, interact clinically, then it should ultimately evolve towards being paid for. You know, one interesting thing I noticed this winter is on a snow day in Vermont, what would typically happen is I got a 4-wheel drive car, I got a guy who comes early, I always get to the office at 8 o'clock, you know, even if it's 3 feet of snow, and then I sit there and do other work because nobody shows up. Now, by 8:30, everyone's pivoted to telehealth and I have a full day. And the ability of our system to just do that simple logistic shift is amazing. So, you know, those are people who would not have been seen, who would have had to delay care or whatever. So, you know, I'm confident that this using this effectively should be paid for. And the question is just, you know, all the policy things that go along with that. So Alexa, I think you're next, unless anybody else wants to try to take a shot at that question.
I was gonna just share something different with Tracy. So you had said there were a bunch of different reasons for, you know, kind of like the spiral down and like less use of telemedicine. And I just wanted to add one from my experience. So I've also done a lot of adult telestroke here at within the MaineHealth network back when we didn't have a full complement of neurohospitalists. So it was pretty unique to be a neonatal neurologist, but also doing adult stroke at various times. But what I found both with the program that I've built in neonates and also with telestroke was that there was this tremendous effect on the ER providers in the community hospitals with their skill set ramping up over time. And so I felt like there were fewer and fewer calls, particularly with the neonatal encephalopathy at the big institutions where or the single big institution where I've trained like 3 hospitalists to become really effective in their analysis of encephalopathy. So I would just say, like, if utilization is the metric, make sure that somehow we take into account the education that we're also providing.
Yeah, building out that sort of capacity. That's the whole concept underlying the ECHO program, sort of telementoring and taking care of patients together. Ben, did you still have a question?
Well, I was going to respond to Gary's comment about reimbursement. I think, Charlie, I think your data showed something like a million telehealth visits a year. Yeah, our provider or our payers don't want to pay for that. They don't want to pay for anything, of course. Their entire business plan is let's collect money and not pay for any care. So that's why they didn't pay for it before the pandemic. There was plenty of data that telehealth was good stuff. So there's just going to be this huge pushback from the payers to take away a benefit that is clearly positive for everybody. It is going to require a lot of political activity to maintain this.
Well, and I think that, Matt and Alexa are great examples of folks who are, getting funding and advancing the science that underlies the reason that we might want to go forward and support it. Matt, you were going to say something?
I was just going to add, and we're at the point now in the project where we're looking to pivot more towards long-term sustainability. And, and as an ER doc, remember, one of the reasons I went into this field is because I was terrified about having an office and a practice and having to define a business model. I just like to spend a lot of resources and not have to worry about where that money goes, right? But in all seriousness, there's value here, right? And so while I entirely agree that we need to advocate to our state agencies and payers that this is good for patient care and should be reimbursed in the long term, we don't charge for Tele-EM because our network has decided that there is enough value in soft savings for avoided transfers and bolstering community hospital revenue that it will support itself. So just for what it's worth.
Yeah, and there is a program here in our adult intensive care unit where they use remote consultation to help sending hospital to decide whether it's appropriate to send a patient to the tertiary center. And I don't know the data in detail, but they do avert a lot of transfers and look at outcomes that include patient and family, mostly family, because these are pretty acutely ill people, but averting those transfers that are so difficult for the family when the outcome is really not going to be positive anyway. And so there's a program here and some good research supporting that. So we have 3 minutes. Any other comments or questions?
Can I just make one more comment? I think what Tracy's doing is so important because I think without the data, we can't make a good argument, and like they're not going to pay because the families feel better to have information, right? So I think personally, I don't love Epic. I always say the motto of Epic is never do in 1 click what you could do in 10. And I just am so grateful that there's people who are patient enough to work with Epic and figure out how to get something useful out of it. And I think, I think if that can really be done in a way that's like, we should leverage this regionally, not just state by state or healthcare, healthcare region by healthcare region, and we can say in the rural Northeast, like this makes a huge difference and here's why, so thank you for leading that charge, Tracy.
Yeah, thanks a lot, Alexa, for that comment, because it really takes us back to what is the goal of the NNE-CTR. It's really to advance research and knowledge across northern New England to try to leverage a larger population that has a fair number of similarities, but it's got some uniqueness to each state in terms of the health policies and politics and somewhat geography. And the collaboration across the 3 states has just been so fun to do. So thanks to our partners from Maine for participating in this presentation. And thanks, Matt. So with that, we'll leave it and we'll see you next time.
Thank you. And everybody should be assured that you folks really are making a difference.
Yes, thank you. Bye-bye.
Bye.